So after we have discussed about the concept of bioavailability as well as a factor affecting bioavailability, let's look into drug interaction, which can also influence ultimate bioavailability of a drugs. Okay, drug interaction can result when one drug alters the pharmacokinetic of another drug or its metabolites. So drug interaction also can reflect the additive nature of pharmacodynamic effect of either drug when taken with the other drugs. Okay, so the pharmacokinetic interaction between investigational new drug and other drug should be well defined during drug development stage as part of adequate assessment of the drug safety and effectiveness. It is important to understand the nature and magnitude of drug-drug interaction for several reasons, because most of the patients, they have concomitant medication, especially elderly, okay, and they take also dietary supplements, okay, or some other food such as grapefruit juice, which may alter the metabolism or drug transport in individual who previously has been receiving and tolerating a particular dose of a drug, and such changes can actually change the metabolism or transport of the drug, which eventually can affect efficacy and also safety of the drugs. So the study of drug-drug interaction for a new drug begins with in vitro study. Okay, so for example, in our previous lecture about the physiological factor affecting the drug absorption, which involving PGP pump and also CYP3A4. These are some examples that how the drug can induce or inhibit the metabolizing enzyme and increase the absorption of another drugs. Okay, so the result of in vitro study will inform the nature and extent of in vivo study, which may be required to assess their potential interaction. So along with clinical pharmacokinetic data, results from in vitro study may serve as a screening mechanism to rule out the need for additional in vivo study, and they can provide a mechanistic basis for proper design of clinical study using a modeling and simulation approach. So when testing new drugs for the possibility of the metabolism, whether it is inhibited or induced, so we can select another drug based on in vitro and in vivo study. Okay, for example, in our previous lecture, we select ketoconazole, if you still remember ketoconazole, as enzyme inhibitor. Okay, then we test with our new drugs. So if the drug absorption differ after ketoconazole is co-administered, then we know the new drug is a substrate for the enzyme. So when the two drugs is taken together, we will potentially see drug-drug interaction. Okay, so the choice of interacting drug can be based on the known or important inhibitors and inducer of the pathway of under investigation, for example, the ketoconazole. So strong inhibitor and inducer provide the most sensitive assessment, and they should be generally be tested first. So the strong inhibitor or inducer, the strong inhibitor for PGP CYP3A4 will be ketoconazole. So these are one of the main examples. So the potential for a drug to interact with the metabolites of the investigational drugs should be also considered. Okay, so metabolite drug-drug interaction should also be explored for investigational drugs that are not eliminated significantly by metabolism, because this drug can actually inhibit or induce co-administered drugs in the same metabolic pathway. So there are a few types of interactions, okay, which is in unidirectional, means drug A affecting drug B, or bidirectional, whereby drug A influencing drug B and influenced also by drug B. Okay, there are four classification of drug interaction mechanism, which is number 1, alteration of drug absorption, number 2, alteration in drug hepatic metabolism, alterations in renal clearance of the drugs, and alteration in plasma protein binding of certain drugs. So when we look into alteration in absorptions, okay, so for example, when we have a complexation or chelation, this is one of the mechanisms that they can change the absorption of a certain drug. For example, when you take antacid with tetracycline, so the absorption of, you will form tetracycline complex, which with a divalence cation, so you form a insoluble complex which reduce the absorption. Okay, and also when the drug is mediated by binding or chelation of drug in the gastrointestinal tract, for example, carbidopa and L-dopa. Okay, when you look at the ferrous sulfate on plasma concentration of levodopa or carbidopa, okay, so here is the plasma concentration of levodopa, and here is the plasma concentration of carbidopa. So the concentration shows, okay, mean value without the triangle, and with the circle means with ferrous sulfate. So this one with ferrous, okay, this one with ferrous. So if you look at the bioavailability, means AUC under the curve, for the one with ferrous sulfate, the AUC is much smaller, which the bioavailability has been reduced greatly as compared to the one without ferrous, because they form complex or chelations to the active drug of levodopa and carbidopa. Okay, ferrous sulfate oral decrease level of carbidopa, levodopa oral by reducing drug absorption from the stomach and intestine into the body when taken by mouth. So iron salt may also affect the action of levodopa. So if you need to administer both drugs, please separate the administration of ferrous and carbidopa by 2 hours. Okay, and this is another example of the effects of antacid on iron absorption from a multivitamin. Okay, so in this study, antacid was immediately administered after multivitamin being ingested. Okay, so you can have a look at the control. Okay, this is the plasma concentration, which is high enough for iron absorption, and when the iron is taken together with NSAID, so the level reduce. Okay, the blood concentration of iron reduce, so which means it will affect the bioavailability of iron. Okay, so compounds that demonstrated to bind with iron include all these drugs. They have the potential to bind with iron, which forming a complex that reduce their own absorption. Okay, so we have finished the complexation of chelation with iron and also antacids. So other possibility in the alteration of absorption will be the altered GI transit. So for example, when we have anticholinergic that ingested together with acetaminophen, the impact of anticholinergic will be delaying in absorption of acetaminophen. Acetaminophen is paracetamol. Okay, so and also it can also be mediated by alteration in gastric emptying or gastrointestinal transit. For example, effect of food on gastric residence time. Okay, so capsule administered to healthy male, which is the one with circle, and female, the one with square here. Right? Okay, effect of food on the absorption of enteric coated aspirin. Okay, correlated with the gastric residence time. So when it is fasting, means we never have any food that interrupt the absorption. So the gastric residence time means how long the drug stay in stomach. Okay, so when you have food, so from less than an hour that they stay in stomach, they increase to 3 hours that they stay in stomach. So when you increase the time the resident time in stomach, you will potentially decrease the arrival to intestine, which is the main absorption site of the drugs. So which means you will delay the absorption. Okay, you will delay the absorption. Okay, these are some of the example of effect of sumatriptan on paracetamol, acetaminophen absorption in patient with migraine. Okay, this is parameter that we assess: Cmax, Tmax, T-half area under the curve. So acetaminophen here, PCM, acetaminophen, this one. So the blood plasma concentration is 26 when ingested alone, but when it is taken with sumatriptan, the plasma concentration greatly reduced. So this is because of the alteration in drug absorption. Okay, so we have completed the complexation, chelation, alteration of GI transit time, and alteration of, so now let's go into alteration of gastric pH. So example, let's say we have a ketoconazole drugs, okay, and when we take it together with H2 blocker, what is the impact? The impact will be dissolution of ketoconazole is decreased. Okay, because when you have the H2 blocker, means you have less acidic condition. Okay, ketoconazole is a weak basic, so it's less acidic, so it's less soluble, so resulting in decrease of dissolution, then decrease the absorption. Okay, and the second drug interaction mechanism will be alteration of drug bioavailability in hepatic metabolism. So in detail, how it happened? It happened by induction of metabolism. For example, when phenobarbital is taken with warfarin, okay, phenobarbital can increase the metabolism of warfarin, which reduce the anticoagulant of warfarin. When it reduces the anticoagulant of warfarin, the patient will have the higher risk of stroke. Okay, so it has to be careful. And also alteration in drug metabolism induction. Okay, the effect of phenobarbital on dichromarole, plasma concentration, okay, and prothrombin time. Okay, so this is a prothrombin time, the white one. Okay, dichromarole, is this one, the dark circle. Okay, so this is the time when phenobarbital is given. If you look at the plasma concentration of dichromarole, initially it is high enough. Okay, so they have the higher longer prothrombin time, but once it is ingested with phenobarbital, the blood level decrease greatly. Okay, and when the phenobarbital is being eliminated and the blood concentration increase again back to normal, and when another dose of phenobarbital is given at 150 on 150 days, it decrease again, and after elimination it increase again. This is showing the effect of phenobarbital on dichromarole. Okay, so this is the detail of phenobarbital and dichromarole on prothrombin time. Okay, please read. Okay, this is another example of mean plasma quinidine concentration in 4 subjects who receive oral quinidine sulfate, okay, before and after oral rifampin. After oral rifampin, you can see that the plasma concentration of quinidine reduced greatly because of the changes in hepatic metabolism. Okay, so alteration in hepatic metabolism also includes inhibition of metabolism. Okay, for example, cimetidine and theophylline. So when cimetidine is given with theophylline, cimetidine reduces the clearance of theophylline, causing an increase in adverse effect of theophylline. Okay, and this is another example with the effect of cimetidine on the clearance of diazepam, desmethyl-diazepam, chlordiazepoxide, oxazepam. Okay, and with control, the blood plasma, the clearance of the drug is higher. Okay, when they are taken with cimetidine, the clearance of the drug is reduced here. So means when the clearance is reduced, so there is a tendency for toxicity. Okay, so here are the example of ritonavir, sacubitril. Okay, sacubitril alone and sacubitril with ritonavir. When sacubitril is given alone, this is a plasma concentration of sacubitril. Okay, so when it is taken with ritonavir, okay, and you can see the plasma concentration increase simply because they inhibit the metabolism of each other. Okay, this can cause a problem of toxicity if the dose is remain as a single dose. So to summarize the alteration in hepatic metabolism, factors that actually alter the hepatic blood flow include, okay, the agent that actually increase the blood flow of hepatic, which is glucagon, isoprotein, renal, phentolamine, phenobarbital, PGE, supine posture, hyperproteinemia, and viral hepatitis. Agents like propranolol, norepinephrine, norepinephrine, anesthetic, labetalol, or upright position, hypovolemic, congestive heart failure, and cirrhosis will decrease the flow of hepatics. When they decrease the flow in hepatic, they will decrease metabolism, and when they increase the flow, they increase metabolism. Okay, so number 4 will be the alteration in renal clearance. So how the drug can interact with each other as a result of alteration in renal clearance, because some drug can increase renal blood flow. For example, hydralazine and digoxin. Hydralazine increase the renal clearance of digoxin, so it will cause ineffective of digoxin. So this is the example of the influence of the vasodilator on renal clearance of digoxins. So when you look at the control, okay, and after the drug, the digoxin is taken with hydralazine, the clearance of digoxin has been increased. Okay, this will cause the reduction in plasma concentration of digoxin and eventually reduce the therapeutic effect of digoxin. So another mechanism of alteration in renal clearance will be the inhibition of active tubular secretion. So for example, when penicillin is taken with probenecid, that probenecid can prolong the half-life of penicillin, okay, and in the conventional therapy penicillin should be given in a multiple dose, and because probenecid can prolong the half-life of penicillin, so it will allow single dose therapy of penicillin. So this is the example of drug concentration of amoxicillin, a group of penicillin, when they are ingested with probenecid. Okay, when you look at the curve of penicillin alone and with probenecid, okay, so you will see the clearance of the amoxicillin is delayed when they are ingested with probenecid, so they can prolong the half-life. And when you look at the clearance, okay, when the drug is given alone, the clearance is increased, and when they plus with probenecid, the clearance decrease. Alright, so another example that how alteration in renal clearance can cause interaction, drug-drug interaction, is by alteration in tubular reabsorption. Okay, for example, when antacid is given with aspirin, okay, the impact of antacids, they will reduce the tubular reabsorption of salicylate via an increase in urine pH. So this will cause the plasma concentration of aspirin eventually reduce. So bioavailability reduce. So this slide talking about the example of the salicylic acid clearance, which increase, okay, when the pH increase. Okay, renal clearance of salicylic in 11-year-old child with rheumatic fever treated with an antacid, because the antacid can cause the change in urine pH. Okay, so the last mechanism of drug-drug interaction will be the alteration in plasma protein binding. For example, when you co-administered the phenytoin and valproic acid, the impact will be the protein binding of phenytoin is reduced, and eventually the total concentration of plasma of phenytoin as steady state is also decrease. Alright, so this is what you call a CSX. So here is the example of plasma concentration of phenytoin when phenytoin is co-administered with valproic acid. Okay, as you know from the previous slide that valproic acid can displace a phenytoin from protein plasma. Okay, so you will have unbound phenytoin, right? Okay, so this is what they observe when the dose of valproic acid increase from 900 to 1350. Okay, the plasma concentration of phenytoin, which is at the time 0 when there's no valproic acid, is 25 mg per liter. So when they increase the dose of valproic, and they noted that the plasma concentration of phenytoin reduced to 11 milligram per liter, and when they further increase the concentration of phenytoin, the plasma concentration of phenytoin further reduced. Okay, oh sorry, just now we talked about increasing the dose of valproic acid. Yeah. Okay, so this means when you increase the dose of valproic acid, you will increase the displacement of phenytoin, and more phenytoin is free. Okay, and they will have the equilibrate between the bound and unbound phenytoin. Okay, so however, what they have observed, actually they found out that even though there's a total decrease in the concentration of phenytoin over time when you administered the sodium valproate chronically, however, the unbound concentration of phenytoin remain almost the same. Okay, this is the observation of phenytoin. Of course, when you displace the phenytoin from bound to unbound, you will increase the total elimination of the unbound phenytoin. Alright, that's why when you administered the drug chronically, and more free phenytoin is available, and more of phenytoin will be eliminated, and the body is trying to adjust the concentration of phenytoin, so they found out that the unbound phenytoin is almost constant. So this can be shown in this graph of plasma concentration of drug displacer, or the total drug that is given, for example phenytoin in the example just now. So when you have the displacer increase in concentration, and you will found out the total drug decrease. Okay, let's say the displacer is drug A and the total drug is drug B. So when you have the displacer A increase, and you found out that the total B decreasing. Okay, the total B decreasing because of higher elimination of B. Okay, when you have the displacer reduced in concentration, then B come back to their normal concentration, and in this case the unbound drug was noted to be almost constant. Alright, this is usually happen for drug with a low extraction ratio. So what is mean by low extraction ratio? Okay, when a drug is taken orally, alright, they will be metabolized in the liver, right? Okay, any drug that they have high extraction ratio means they will be extensively metabolized by the liver. Okay, so when the drug has a low extraction ratio, okay, due to a certain factor, for example there's lack of enzyme for the elimination, or maybe involve a specific carrier for the metabolism. That's why for drug with low extraction ratio, they do not undergo extensive metabolism in the liver. So no extensive metabolism in the liver. So this phenomena here, that when you have the displacer of A against B and you observe the unbound drug is almost constant, happen only to low extraction ratio drugs. Okay, so this is another example that we can see for warfarin, okay, and phenylbutazone. Okay, when you administered warfarin in the beginning, time 0, and this is the curve, at around day 11, when you start the phenylbutazone, you can observe that the total warfarin goes down, okay, because phenylbutazone, they displace warfarin. Okay, when they displace warfarin, the total warfarin go down. However, the unbound warfarin was noted increase. Okay, and please be noted that warfarin is a type of drug with low extraction ratio. Alright, so by right you will observe that the unbound drug should be almost constant, right? However, in this case, it is an exceptional where you saw increase in the unbound warfarin. So that's why in this case we suspect, okay, after the administration of phenylbutazone, okay, there is an inhibition of warfarin elimination that causes the unbound warfarin increase. Okay, and when you stop the phenylbutazone, that the total warfarin increase back to their normal level, and the unbound warfarin back to the normal level as well. Alright, so this is one of the exceptional that you can see between warfarin and phenylbutazone. It means that there is more mechanism involved between the interaction in the interaction between warfarin and phenylbutazone. So this is the example of drugs. I think it's the misacochine, sinecertin, that co-administered with ketoconazole, and it will change the plasma concentration of sinecertin. So what is the role of ketoconazole in this experiment, and what is the implication of the co-administration of ketoconazole, and what you can conclude from the result presented? So have a thought on this graph, and we shall discuss in the class. So see you later.